Good evening, everyone. Thank you for joining us, and welcome to another London Middlesex Primary Care Alliance Town Hall. Another one focused on some COVID questions and some things that are currently happening in our system. My name is Janet Dang. I'm the Primary Care Transformation Lead, and I have along with us a number of our LMPCA Executive Council members here tonight. So I wanted to quickly go over some technical issues and things that we have. Everyone is placed on mute currently. And if you have any comments or questions, please feel free at any point to type in the chat. There will be times for you to unmute and ask your questions and have some dialogue as well. And lastly, the event is being recorded. So if there are colleagues of yours that are unable to join us tonight, please let them know that the recording and the resources shared tonight will be shared through the London Middlesex Primary Care Alliance's newsletter as well. So to start, please feel free to type in the chat box who you are and introduce where you practice or which organization you're with, and we'd be happy to get to know some more of our London Middlesex Primary Care Alliance community. And I will hand it over to Nor to welcome and begin.
Hello all, welcome. My name is Nor Alfrawi, nurse practitioner with the London Middlesex Primary Care Alliance Executive Council. It's my pleasure to welcome you all to our very first LMPCA Fireside Chat. We're all very excited to have you here tonight. Our focus is everything COVID, tailored to primary care. So COVID has been here for 2 years, but everything keeps changing on us. So tonight is a peer-to-peer discussion where we will learn together the most up-to-date information we have on how to tackle COVID in the office. We'll cover various topics. Please feel free to type questions in the chat box and we can discuss as we go. If you want to come off mute and ask your question, just raise your virtual hand and our moderators will take care of the rest. We have noted the questions that were sent upon registration and we'll also answer them throughout. We'll also have an official Q&A at the end. I just want to stress that this is a peer-to-peer discussion, so your participation is most welcome. We're all in this together, and while guidance is available, it's not always 100% clear. If through our discussion we find there are some outstanding answers, we will get clarification from Dr. Summers and the MLHU and bring it back to you all. If you feel you have some good information to share, please feel free, as we can all take this opportunity to learn from one another. So without further ado, let me just introduce some of our LMPCA Exec Council members who will be taking part in tonight's Fireside Chat. Dr. Vineet Nair, Dr. Gord Schachter, Dr. Jessica Hunter-Orange, Dr. Stephen Wetmore, Dr. Scott Mackay, Dr. Julie Clark, and Dr. Phil Vanderwall. And of course, a special thanks to Janet Dang and Drina for all their work. So let's get started. Great, so our first topic is IPAC and PPE use. So first few questions, so feel free as we go on with this topic. If questions pop up, our moderators are checking, so let us know and we can answer them as we go. So I have a couple questions just about N95s, and Phil, I was wondering if you can help me out with that. So if I wanted to order N95s for my office, where can I do that?
So N95s until very recently were actually very much not able to be obtained by primary care. However, recently HMMS has allowed access to N95s. They're 1870 plus, which fits pretty much 80% or so of people's faces. And they will give you a big box if you order them of 440 masks. So please feel free to order.
Awesome, thank you. And
can we give you the website? I think maybe Janet, you have the website to put up for that.
Perfect.
Thanks, Janet. It's in the chat, folks.
Wonderful. So we all know N95s are most effective when properly fitted. So I don't know if you or Gord wanted to answer this, but where can we go to get fit?
Sure, I'm happy to answer that. So, there are private organizations that do N95 fit testing. If you are a family physician that's affiliated with London Health Science Centre, you obviously probably have already been contacted by Medical Affairs that you can get fit testing done there. However, the Western Ontario Health Team has organized to get some free fit testing in the community. So we just put up a slide. This is going to start next week. We did a bit of a soft launch this week. I think yesterday or today, they did 16 people just getting themselves organized. So this will be done at the Thames Valley Family Health Team office, which is at North Rutledge Park. There's the different dates that are being offered. We have the contact information here. We will make sure an email gets sent through to everyone. That will be coming probably in the next few days through the OMA channels. This will be open to both family physicians in the community and specialists in the community. So we want to ensure that anybody who's in the community has access to getting N95 mask fit testing.
Awesome. Thank you. So back to Phil there. When you're using N95s in your office, like how do you go about that? Which patients and do you reuse your masks? If you do, are there any strategies that you use?
Good question. N95 masks are by directive 1 to be used with all patients who are COVID positive or who you suspect are COVID positive. So we should be seeing those patients with N95. Patients who screen negative, we are encouraged or welcome to use a well-fitting surgical mask. With each of these, there is a suggestion that adding eye protection will improve somewhat your likelihood of not getting exposed to COVID. Probably more important when a person who you're seeing has to take their mask off for any reason. So for the most part, what I do in my office is I tend to wear a surgical mask and I use goggles. Some people will use a visor, but anything that sort of protects both your eyes and your airway are the two most important things. Some people choose to use N95s for their entire shift. Once they sort of have their N95 on, they want to continue to use it. Certainly not needed for most of family practice, and Dr. Summers recently sort of re-emphasized that we do not need to, for low-risk people, use N95s. I think it's important for each of us to think about our own risk and make that risk assessment on a professional basis, but we need to make it also with the understanding of what is best practice at this point. So for the most part, N95 should be used with our screen positive patients for whatever reason that they screen positive. Can you reuse the mask if you take it off and keep the mask, the part that you would actually put over your nose and your mouth, if you can keep it clean, such as in a paper bag? That is certainly a very reasonable thing to do. Some people will tend to have bags for sort of Monday, Tuesday, Wednesday, Thursday, Friday, and you can certainly reuse them over multiple days. If you do contaminate a mask with COVID, 3 days in a paper bag will certainly kill the COVID, and you don't have to worry about it being contaminated anymore. So there's certainly lots of things that you can do to sort of save a fairly precious resource, really. So that's sort of what I do with my N95s.
Great. And those patients that you see that screen positive, when you see them in your exam room, do you leave like a fallow period or interval period between seeing them and like a COVID negative patient, for example?
Yeah, I think the recent advice is that we don't need to do that, that there is very little sort of COVID left in the room after the patient leaves. Some people, however, feel that, their air circulation isn't very good in their room and that sort of thing, so they may want to do something of that nature. But the likelihood of contracting COVID for the next patient, especially if everybody is masked, is almost nil.
Yeah, that's fair. Similar to masking, just in general, we know that the guideline now for the general community is medical masks are better. What are you doing with your patients now if they come in with a non-medical mask, and similarly with I guess with staff, they would just wear a medical mask, but what about those patients that are wearing the fabric masks? Are you having them switch to a medical mask?
So in general, if they have a mask that's sort of, fitting over their mouth but not over their nose, or, one that is just way too big for them and keeps flopping off, I will usually offer them a new medical mask and ask them to wear it appropriately. But for the most part, if they're wearing their cloth mask in an appropriate manner, I would not ask them to remove it.
Okay. And one of the questions that we were asked by one of the registrants was just about air purifiers. And I was just wondering your opinion on that, if any. Is it necessary to have one for in-person visits that last longer than 15 to 30 minutes?
Yeah, it's certainly a question that people have asked. I think, again, if you have a person whose mask has to be off for whatever reason for an extended period of time, would be about the only time that you would ever consider thinking about something of that nature. So in general, I would say that most of us in family practice would not have to worry about that sort of thing, and certainly I don't worry about that, at least not to this point.
Yeah, I agree with you. And to the similar point that you made earlier, just about your risk controls and things like ventilation and the size of the room and all of that come into play. Things like screening and prevention are all a lot more effective than the filters themselves.
Absolutely, yeah.
So,
and we're not doing AGMPs, right? I mean, so
exactly.
So if we were doing AGMPs, that'd be a whole different story.
For sure. Just checking the chat box here. Doesn't seem to be any questions about IPAC and PPE use. So we'll move forward to the next topic regarding vaccinations, and I'll hand over the mic to Julie and Jessica.
Actually, I just might mention there is one question about endoscopic procedures, and that's got a bit to do with the question that Phil was just addressing. So maybe there's no need to worry about air circulation in a small room, but when you're doing aerosol generating procedures, can you ask for vaccination status and book them at the end of the day? Anyone want to address that?
So I just was going to look on the CVSO website. So they have some guidelines around what we can do for patients. I think it's okay to ask for vaccination status as long as it's not used to deny care to patients who are unvaccinated. If you're using that to say cohort patients who are unvaccinated, my understanding of the CPSO rules would be that is it would be okay, but we cannot be asking for vaccination status to refuse to provide care to patients. I'm not sure if anyone has anything else to add.
I was just going to add, if you're using appropriate PPE, theoretically, it shouldn't make a difference if what the vaccination status is of the patient. Obviously, for endoscopy procedures, there's an aerosol element to it, which means your facility should have the proper setup from ventilation for it. And again, that should not make the difference then, as long as you have that set up and you're using proper PPE. That would be my understanding of it. Because the status of vaccination is not the issue. The biggest key is doing that pre-arrival screen for symptoms, and hopefully individual patients are honest with their answers. That's, I think, one of the things that all of us in family practice have found, that we have some patients who sometimes don't answer those questions appropriately and say, oh, by the way, I have a cough, and we've all seen that.
Thanks, Gordon Scott. So yeah, so I'm going to chat with Jessica a little bit. It's great to have Jessica's expertise as someone who's done thousands of doses at the Agriplex and other mass vac sites. So Jessica, one of the issues that comes up in family practice is trying to convince pregnant women to be vaccinated. What hints do you have for us to help with that?
Yeah, that's a great question, Julie. And obviously, moms and moms-to-be have concerns about that. But thankfully, at this point in the pandemic, we've literally given hundreds of thousands of doses of mRNA vaccines to pregnant persons. And we have seen no abnormal signal in pregnancy loss, and stillbirth or any poor fetal or maternal outcome. We do have a really nice 2-page PDF that's from the Provincial Council for Maternal Health. And hopefully we'll be able to put that in the chat because it's really nice. It's a really nice infographic that kind of is something that patients can take home, because sometimes even the conversation you have with them is still not good enough, but it's just that take home piece can kind of highlight that, because we know that 20 to 30% of pregnant people who do get COVID-19 can have poor outcomes in terms of requiring hospitalization, ventilation, and problems with and at delivery. So it's not a benign illness, even Omicron, for pregnant people. So we need to highlight that. And there was a memorandum that was just sent out that I've got here from the Chief Medical Officer of Health, really asking us as primary care providers to strongly encourage COVID-19 vaccination in this population. So, us as family physicians, obviously midwives, OBs, they all have this as well. So we really do need to be doing that. This is a safe vaccine, whether it's Moderna or Pfizer, it doesn't matter. But at this point, 3 doses is ideal.
There's a similar hesitation, or a hesitation also to get booster doses amongst people who have had Pfizer before and want Pfizer again. But we're trying to tell, we have to explain over 30, it's going to be Moderna. How do you explain that to people?
Yeah, I've had this discussion with many people, especially recently, because prior to Christmas, we had a lot of Pfizer. Now we don't have so much Pfizer. So now, Jenna, if you can put up the slide that actually shows the population that we're vaccinating now. So right now, so this is right now, okay? So this could change in a week or two. But currently, the 18 to 29-year-olds, and as well, obviously, the 12 to 17, because that's the only vaccine that's been approved by Health Canada, is Pfizer. So we are giving the 18 to the 29-year-olds a full dose of Pfizer, which is really 30 micrograms of mRNA, okay? Anyone 30 and above to the age 69 is going to get a half dose Moderna. So it's a 0.25 ml, and it's a 50 microgram dose, okay? So we do believe that Pfizer induces a somewhat higher level antibody response in comparison to Pfizer. And when you actually look at a full dose Moderna versus a full dose Pfizer, you're looking at 100 micrograms versus 30. So the rationale to bring it down to a half dose or 50 is quite reasonable. The other setting where we're actually using a full dose is age 70 and above. So the age cutoffs for these doses are the age of the patient while they're sitting in the chair in front of you, okay? So it's not turning 70 this year, it is how old are they sitting in your chair, and those are the guidelines for which you have to decide which dose and then which vaccine, okay? So hopefully that's clear. Thanks, Julie, for putting that in there. These are the actual, there's the website.
And what about the other questions are about the timing of the vaccines, the timing of, first of all, the timing of boosters for people under 18, the timing of second doses for pediatric, those timing questions. Can you go over those?
Yeah, so basically, as long as you are 3 months, so this guideline has obviously changed recently. As we know, things change on a dime. Some days it feels like things are changing hourly, and I'm sure you guys feel that too, I do. But it really is 3 months from your last dose, you can get your third dose or booster. So there's been some kind of back and forth, whether this is the third dose of a primary series of 3 doses or if this is booster. Seems to be kind of boosters kind of catching on as the term. Whether or not that's correct, I guess, remains to be seen. But as long as it is 3 months from your second dose to get your third, okay, and that can be any age population 12 and above, okay? Now, in terms of the kids between the ages of 5 and 11, this is where the controversy starts to begin. And you get probably half of us are saying, okay, let's give it at an interval less than the recommended 8 weeks. So currently right now, the NACI and the Ontario Ministry of Health is recommending children between the ages of 5 and 11 get their second dose at 8 weeks. And the rationale for that is simply because we do believe that you are going to get a longer sustained immunity. The thing is, you have to balance that with the risk of the disease in the community. And as we all know, the risk of the disease in our community is very high. So some parents, now that we know kids are going back to school on Monday here in Ontario, we know that the risk is higher for our kids now that they're in class as of Monday. So many parents have chosen to shorten that interval. The shortest you can do is 21 days, but as long as the patient, the guardian is given informed consent, they are able to choose that shorter interval for their child.
Yeah,
so just along that lines, there's a question in the chat about how to handle if people are asking that they want their booster sooner than they qualify, and if there's any recommendations or what people are doing to handle those situations.
So at what age are we asking here?
This is for an adult. For an adult coming to your office asking if they can get a note to get their booster sooner. Aha.
Well, the thing is, I find most, well, I mean, I guess we can't say most people, well, it probably is most, actually, now that I think about it, that would have had their second dose some time ago. But my understanding is we are sticking to the 3-month window, and anyone can correct me if I'm wrong on that. No? Okay. I do see a question in the chat. Thanks, Kristen. Is there a higher chance of myo or pericarditis with those 5 to 11 with a shorter interval of 21 days? My understanding is the risk of myo and pericarditis in this age group is extremely low, like very, very low. I can't give you an exact number, but literally I believe there have been only a very small handful of cases reported in the United States. Obviously they were, 4 to 6 weeks ahead of us in terms of vaccinating this age group, but my understanding is it is extremely low risk.
So the interesting question is using the word qualified, like when do people qualify for a second dose? So I think the way the health unit would say it is that parents can make that decision. That's a decision that you can make, that it's recommended it be 56 days. You can have it at 21 to 28 days. Where you fall in between there does depend upon your circumstances, such as if you have an immunocompromised grandmother at home or something like that, possibly. Jessica's question, a pediatric question about a 17-year-old with CP, about giving a, maybe you're asking about whether to give a booster to that young adult. The booster for people under 18 has not come yet, correct?
Correct, yeah.
The interval for second dose would be the same regardless, because he would have to follow that guideline. But what do you say, Jessica, about or Jessica Hunter Orange, sorry, there's two Jessicas here, about when is it going to come out for booster for under 18s? Parents are worried about that.
So I don't know. So the thing is, right now we don't have booster doses other than for people 18 and above. The 12 to 17 age bracket currently in Canada is not eligible for a booster at this time. That being said, just last week, the FDA has approved, they had previously approved 16 and 17 to get a booster, and they, for some reason, used that group first. And then now they have approved 12 to 15. So I suspect, and I have no basis other than just history to tell you that I suspect that we are going to be next in line for that. We tend to be anywhere from 3 to 8, 10 weeks behind, some of the decisions the FDA makes that Health Canada then follows. But at this time, no third doses for anyone between the age of 12 and 17, but stay tuned.
Stay tuned. Okay, good. And our other timing questions that come at our secretaries all the time on the telephone are, I just got COVID, so when should I get my booster? I have to cancel it, when should I rebook it? Or my spouse just had COVID, when should I get my booster?
Yeah, this is also a bit of a debated topic as well. So some sources are suggesting that as soon as you are recovered from COVID-19, you can get your third dose, okay? So as long as you're feeling well, you feel fully recovered from COVID-19, you can get your booster. So here locally, if you show up in your day 12 or 14 and you're feeling well, I don't believe they will turn you away. I haven't turned anyone away, and I vaccinated a few of these people. There are other sources who are suggesting wait 30 days. So the Chief Medical Officer of Health of Ontario has made a public statement to say wait 30 days. Other leaders within Infectious Disease and Immunology in Canada have also suggested 30 days. And the rationale for that being that after your primary infection, you obviously do have some immunity. And then the thought is you're protected for that period of time prior to then getting your third dose. So you kind of then have potentially, in theory, a longer period of time of immunity if you then delay the booster. And some people have even suggested beyond, I've actually read something this morning that said beyond 30 days. So it is a very individualized decision. And it's a very personal one. So I think that, the caveat being that you're fully recovered, you can get it. If you wish to wait a little bit longer, you're supported in that decision as well.
Okay, last question is, what would you say to a medical staff who doesn't want to get a booster?
So at this point in time, to be, as I said, fully vaccinated in Ontario, you only need your 2 doses. As I said earlier, Saskatchewan today has now said that to be fully vaccinated, you need 3. So all you can do is really educate and suggest that they get it. You cannot force them to get it. At this time, only the 2 vaccinations in Ontario are required. But we do know with the Omicron variant that absolutely you have far better protection if you do get your 3rd dose. So highly encourage. Ask why. Why don't you want to get it? Do you have a concern? And then try to see if you can address that. But I do think the 3rd dose is quite key, especially for our medical staff. I'm looking in the chat. Thanks, Mario. Here you go. As per CDC, 8.6 million vaccine given between the ages of 5 and 11 between November 3rd and December 19th. Only 12 cases of myocarditis, all discharged home and recovering. That's pretty powerful set of numbers. So thanks so much.
Great. I think that if there's any other questions about vaccinations, you can put them in the chat and we can come back to those. But now I'll turn it back to Noor.
All right. So next topic is just regarding isolation protocols for patients and healthcare workers. And Vineet, I'm going to pick on you for these questions here. Let's say I develop symptoms of COVID but tested negative, but 2 days later test positive on COVID on a rapid test. Does my isolation period start from the onset of symptoms or from the positive test?
Yeah, so I mean, I think all these isolation protocols are kind of complicated and seem kind of complicated, I think, to all of us. It's hard to get a clear answer to some of these scenarios, as you can see in this kind of little joke that was on social media there earlier. There does seem a lot of scenarios that are kind of hard to get our heads around. So that's kind of what we're going to talk through some of them here today. Yeah, so in terms of the case you're talking about, having symptoms first, initially a negative test, and then having another test a couple days later that was positive. From my understanding is that you would go with this one that came first in the scenario, like whenever you became symptomatic would be your day 0. And then you kind of go forward from there for the 5 days of isolation if you're fully vaccinated.
Great. I had a question just about eye protection. I know it's recommended generally in all cases, but let's say, you saw a patient and they screened negative and you weren't wearing eye protection, but later, they ended up having symptoms and either tested positive or had symptoms. Would the not wearing the eye protection then count you as not wearing proper PPE or consider you a close contact, or is that not considered? Yeah,
it's a bit tricky. I mean, my understanding is that eye protection is part of PPE. So if you were with somebody in that same kind of context of being in an exam room without, seeing that patient for 15 minutes without proper PPE, that could be considered close contact. I guess the debate is whether if the patient is wearing a mask, is that still considered a close contact or not? And if you're not taking the mask off at any time, it's a bit questionable. I think to be on the safe side, I think that's why I think we all recommend wearing the eye protection at all times, just in case you're in one of those kind of situations where you might get tripped up. Not sure anybody else have any thoughts in that scenario, because again, this is a team effort for these kind of complicated ones sometimes. But that's my understanding, is that if just to be on the safe side, wear one, but just in case you got contacted, they may call you on saying that you are considered a close contact.
Yeah, I would definitely just err on the side of caution with that. Yeah, for sure. What if this was a question that was asked with one of the registrants, is what about patients who had positive PCR and had no symptoms, but PCR is still positive? When can they go back to work?
So your isolation would still start if you're asymptomatic. Your isolation starts on the day that your test comes back positive, whether that's with an RAT or with a PCR test. The RAT test should become negative after 5 to 6 days. The PCR may last positive much longer than that. So realistically, it's still the date and the number of days is still the criteria to follow to come out of isolation.
Awesome. And another question that was asked is, are there any exceptions to isolation guidelines that apply to healthcare workers or their children who are newly symptomatic if they have recently had confirmed COVID?
So if they had recent confirmed COVID, like had a PCR test or even an RAT, my understanding is still, like, again, it's not super clearly written down anywhere that I've seen, but I've kind of heard it in the ether somewhat that, you know, if you've had a confirmed positive COVID and you had symptoms down the road, like within the first after 90 days, that you wouldn't have to isolate because you just had COVID and your risk of getting COVID again would be very low. Again, I would almost double check that though with your employer if you're working at the hospital kind of setting, but because it is not something that's clearly said in any kind of Ontario guidelines that I've seen. And if anybody else has seen that written down, I tried to find it because I've heard this a lot, but I don't know where I've seen it. So I wouldn't mind having something documented to kind of confirm that. That is my understanding. There's a couple of questions here in the chat I just wanted to get to. So I want to talk about, is it 5 days after symptoms of COVID? If you're double vaccinated or triple vaccinated, right now the protocols are all based on 2 vaccinations, so it's not the 3rd one. So if you have 2 vaccinations, you would still be the 5 days for isolation.
Awesome. If we can go to the next slide there. So we just have a couple of scenarios, again, just to generate some conversation. So Dr. J is fully vaccinated, runs a family practice, and is asymptomatic, but her 4-year-old daughter has developed a runny nose and low-grade fever. Does Dr. J have to isolate? If so, when can she return to work?
So in this scenario, we basically have a fully vaccinated individual that has a close contact that they live with. So in that scenario, the whole household would have to isolate for the 5 days and feeling better for 24 hours. I think that's another part. You have to have no fever for 24 hours and feeling better for 24 hours before you go back. So if you're still symptomatic at day 6, you still have to isolate further. And the whole household has to isolate as long as that symptomatic household member has to isolate.
Okay, perfect. Just a question in the chat there. What is the isolation and testing protocol for an unvaccinated staff who comes in contact with a COVID positive coworker? Vaccinated staff is wearing a level 3 mask and unvaccinated staff is wearing a level 2 mask without eye protection. Thanks.
Yeah, those are all good questions here. So again, this looks like it would be like a close contact because again, not wearing eye protection, you could be considered a close contact. And assuming you're a coworker, depending on how closely they work together, if they're on the same desk next to each other for a long period of time of the day, I think it would still be considered a close contact. So that unvaccinated staff member would have to be isolating for 10 days. Again, if you're a fully vaccinated individual with a close contact, it is simply self-monitoring for symptoms for 10 days. So it's quite a marked difference in terms of protocols if you're a close contact of a case or a symptomatic individual, if you're vaccinated or if you're unvaccinated.
Agreed. It just comes down to the eye protection and whether we would consider that being unprotected. Yeah. If we can go to the next slide there. So this is just the MLHU guidance with what Vinny just said. If you're fully vaccinated or under the age of 12, you only have 5 days, and for those who live in your household would also need to isolate. Next slide.
Yeah, and just to clarify that, I mean, the under 12 piece is really a bit because of, although they're not fully vaccinated, it's because they haven't, some of them have not had a chance to have 2 doses yet. And it is somewhat of a balancing act between, reducing risk and also keeping kids in school and keeping things functioning. So there is a lot of factors in play, which kind of causes some of the inconsistencies you may see on some guidance, some experts that you see on social media or on other news networks. It's a lot of differing opinions on what to prioritize more and how to choose what to do. So I think that's why there's a lot of uncertainty and sometimes different interpretations of the guidelines or different feelings on whether these are the right ones or not. But these are the ones we have and the ones that we're following at this point.
For sure. And this is just a slide from the Ministry of Health, really outlining the same things that the MLHU website does, but more in an algorithm form. You can also find it on the OCD website. I just thought it would be nice to share a couple of resources that we generally look at and are frequently updated.
Yeah, and because of the confusion of this kind of stuff, I have seen a lot of other family physicians and people that are trying to put together their own guidance, like flow sheets, to make it more palatable for all of the different scenarios in one sheet. So I'll share those in the chat when I get a chance to as well. There's one from the Marathon Family Health team. Another one, the family physician, has also created a kind of a more complicated one, but it has all of the different scenarios on there quite nicely. So I'll share that in the chat shortly.
That's great. The only thing I would suggest with those is sometimes I always like to look when it was last updated. So I would never like print or have things, you know, because they can change so quickly. So it's always good to know, you know, when things are last updated.
Good point. Absolutely.
Next slide. Thank you. So what if Dr. J develops symptoms 3 days into her isolation? Does she need to reset her isolation?
Yeah, so this scenario, Dr. J was a close contact, fully vaccinated close contact, and now has become a symptomatic individual who is fully vaccinated. So she would now go to that other pathway of being a symptomatic, fully vaccinated individual, would have to isolate for 5 days starting on that day she develops symptoms.
Perfect. And what if 1 week later, Dr. J's partner develops COVID or has symptoms? Does Dr. J need to isolate again?
Yeah, that's a tough one. I mean, I think, yeah, that's a really tough one to say, because I mean, it depends if Dr. J is this the same case or not. I mean, it would be easier to say if her partner developed symptoms like while Dr. J was still symptomatic, then you wouldn't have to, right? Your 5 days are up, but then that would be it, and that would be at the end of it. But if it's a new set of illnesses, like a new bug that's come into the household now, then you would have to do the same process of isolating for 5 days as a close contact of a family member that lives with you.
For sure. Yeah, the first two questions are more just to generate discussion. I don't know if there's anything really written in the guidelines, and you know, we could always defer, you know, peer to peer, or even asking our local health unit in specific scenarios like that. What if Dr. J's daughter did not have a fever but only had a runny nose and was otherwise well? Do Dr. J or her daughter need to isolate?
Yeah, I mean, if you go through the provincial symptom screen now, which has changed again, been updated, I think as of December 30th or whatever, it is now changed of the symptom list. So it is, runny nose by itself is not indication for isolation at this time. So it's the cough, shortness of breath, fever, loss of taste or smell. Any one of those you would isolate, but then it's two of the other symptoms of myalgias, headache, runny nose, sore throat, extreme fatigue that would lead to isolation. You have to have two of those symptoms.
Perfect. Next slide, please. Great. So this is just basically outlining exactly what Vineet said. Is on that left side there, was just one of the symptoms. Then you would just need to isolate for until you're feeling better for 24 hours. Or if it was a GI symptom, then it would be 48 hours. So same thing, if a healthcare provider, one of us, had a sore throat, same thing, we just isolate until we're feeling better.
Yeah, and I think we have to really kind of keep reminding ourselves about that 24 hours feeling better piece. I think that one is kind of, we get too focused on the 5 days part and forget about the feeling better. I mean, thankfully, it seems like Omicron seems to be fairly quick up and quick down with the symptoms. So it may not come into play that much, but certainly I know we've all had patients that have still been symptomatic on day 7, day 8, what have you.
So Joe is a medical office assistant in a family practice and is fully vaccinated. He has started to experience symptoms. He goes home to self-isolate. Do the rest of the staff at the clinic need to also isolate?
So again, this depends a bit on who's a close contact and the vaccination status of everybody else. So if everybody else is fully vaccinated, then they all just have to self-monitor for symptoms for 10 days. If somebody is not vaccinated and is a close contact, then they would be a close contact of a symptomatic patient, they're individual, so then would have to isolate for 10 days as well. So it depends a bit on how much the contact was. Truly a close contact. Does that meet that criteria of being in the same space for 15 minutes without proper PPE, and then vaccination status?
100%. So in the next slide, that basically outlined the definition of close contact, like you said, Vineet, and if that's the case, they would need to isolate if they're partially vaccinated, unvaccinated, or immunocompromised. The other thing to consider, if that's the case as well, then they would also need to avoid any going to any high-risk settings for 10 days as well.
Correct.
Yeah, so scenario 3, your patient Nancy's booked for an in-person appointment. Her partner tested positive for COVID 7 days prior, and they have been self-isolating. Nancy's husband still has symptoms, but no fever and is feeling better the last day or so. Nancy's fully vaccinated and did not develop any symptoms. Is Nancy eligible to leave self-isolation at this time?
You really danced the line on the gray areas there, Nora. So, I mean, I think, yeah. So, I mean, basically, if her partner is 7 days out, no fever, and has been feeling better for 24 hours, then his isolation would be over, and then Nancy's would also be over, and so she could come to the office at a time, so her screen would be negative at that time.
Agreed. And if she wasn't vaccinated or immunocompromised, then that would go to 10 days, correct?
Correct. Yeah.
Yeah. Awesome. And if his symptoms didn't improve by day 5, would she still need to isolate as well?
I mean, if he hasn't improved for 24 hours before the appointment, then she would still have to continue to isolate, because he would still have to isolate. Yeah.
For sure.
Sorry, I guess I wanted to come back to one little piece. We kind of mentioned a bit about the higher risk settings too. So the 5-day isolation, like self-isolation, is if you're a healthcare worker, is to don't have to be isolated for just regular things. And in terms of coming back to work in a lower risk healthcare setting, which primary care is considered to not be a highest risk type setting. But if you were also working in a hospital or long-term care, you would still have to wait another 5 days for a full 10 days before going back to the highest risk settings. So just to be a reminder of that distinction.
So again, this is just relaying the evidence of the discussion there. I think we all understand that we need to isolate for the same length of time as the positive case. Next slide there, please. Thanks. So this is along the same lines. If John is vaccinated and a primary care provider and his wife tests positive for COVID, but her isolation period is 10 days because she's immunocompromised, for example, is John's isolation period 10 days or is it 5 days?
So my understanding is that your isolation period is the same as a symptomatic person. So if Susie needs to isolate for 10 days, so does John. And I'm gonna just go on a guess that it's because if she's still potentially symptomatic for longer, shedding virus for longer, then he's exposed for longer. Maybe that's not the reason why, but that's my understanding of why that would make sense to be the 10 days as well, despite his vaccinated status.
Agreed. Yeah, and that's the picture under the scenario there is outlining that. I believe that's from the Ministry of Health guidance. Great. So now I'll hand the mic to Julie and Gord and Phil, I believe, for testing and assessment.
Great. So the big questions circulating now are healthcare providers and primary care settings to keep us at work. If we get symptoms, should we be tested? Are we eligible? And if we're exposed, should we be tested and are we eligible? Gord.
Yeah, thanks, Julie. So as healthcare workers, we meet the criterion that the ministry set out for getting tested because we were working in a healthcare setting and we have the potential to be seen symptomatic patients or probable COVID patients. So we are eligible to get tested. You can book testing through the regular assessment center in Carling through the online portal. And there's also through that online portal, you can also book at the Springbank site, which is now doing the rapid molecular test, which is a rapid PCR, which gets you results in about 15 minutes. So you're not needing to wait the 24-hour period either. So it's just another great option that's been provided to us in the community for community providers.
What about if we're exposed or if we have symptoms, what about retesting ourselves before returning to work? Is that necessary after an isolation period?
Yes, the isolation period is pretty much clear as defined as if you're vaccinated, the isolation period is 5 days. There's no need to be retested to go back to work. The retesting is mainly for the congregate settings and the highest risk settings. And so primary care not considered high risk and thus it's not needed.
But if you also have a job, if part of your job is somewhere else, then you would.
Then you need to go by their occupational health and safety standards. So if you work at a long-term care home or if you work in a hospital setting, then you may need to follow their occupational health protocols. So for example, you may be able to go back to your office, but you may not be able to go back to the long-term care or the hospital setting.
Okay. And Gord, do you want to run with giving us an update about assessment centers?
Sure. So this is sort of some new things, and I did get put a slide in there to help explain sort of what's been changing. As we all know, the testing criterion has significantly changed, and as a result, the assessment center volume has significantly gone down from 500 to 600 a day they were doing to about 100 to 150 a day. Ontario Health has asked all the assessment centers to take a look at changing what they're doing or pivoting a little bit to still be doing the testing that they need to do, but move into what we're calling more of a clinical assessment center. And the idea behind the clinical assessment center is with all the volume of Omicron or COVID that's out there, we have a huge influx of patients that are presenting to the emergency room. And this is just a way to try and divert the emergency room patients who have COVID-based symptoms to another spot where they can get assessed, decrease the volumes that emerge, and decrease the likelihood that there's any transmission for some reason in a waiting room type of setting. The idea, though, would be that this would not be assessment for the mild symptoms. That individuals with mild symptoms should be able to contact their primary care provider first for providing care. And whether you choose to do this virtually or in person, that will be your choice depending on the nature of your office setup, the PPE you have, and your comfort level. But if a patient is experiencing worsening symptoms, especially, for example, I'm just thinking of two of my patients, husband and wife, that were unvaccinated, were significantly sick. This would have been a great opportunity to have them assessed for a more higher level assessment, including oxygen saturation assessment too. We would hope that anyone with mild symptoms that you're seeing, though, you would consider getting them some type of access to a pulse oximetry. And there's two ways you can do that. One is through the home and community care remote patient monitoring. The other is something called COVID at Home, and we'll put those links up on top. We also did spread the referral form for the home and community care program a few days ago on the Primary Care Alliance website, just for if you want the EMR-based referral form. But the idea is oxygen saturation is going to be your biggest clue as when somebody's getting sicker, right? And so that's one of the most important things to be looking at. So this new assessment center change is going to be soft launching early next week with a little bit of a hard launch later on. So there'll be more formal announcements and probably time maybe by the end of next week, along with more ministry announcement. This is not meant to be, we're going to try and discourage patients with mild symptoms from going there on a walk-in basis. That shouldn't really be what it's for. We would hope they would seek out primary care. However, we do know that there are patients who do not have primary care providers that will probably still seek it out. So this is just a little bit of background of the guidance from on the assessment centers from Ontario Health. I'm not going to go into too details, so we can probably move on.
Gord, I'm just going to interject for a second. Is
Sure.
this clinical assessment center for adults only, or are children going to be eligible?
It is for both. So again, pediatric patients, again, as primary care providers, we should be able to assess them. The other option for a pediatric patient who is getting more severe, and there's some criterion, is there is a COVID virtual pediatric clinic, which there is a referral form that has been shared. Talking to the clinic today, they are extremely busy and have certain criteria for which patients they would see. So they do not want to see mild patients. They're going to try to put out a one-pager very quickly for us to spread for primary care so that primary care providers can understand what it would be an appropriate referral to the pediatric COVID virtual clinic. But the assessment center would see these pediatric patients.
Thank you.
And we'd like to also talk about rapid antigen testing, which is another big question we get asked a lot about. Confusing messaging. Phil, if you'd like to turn to this topic, when do you think primary care should be looking at rapid antigen testing?
The big question, Julie, is whether you can actually even get them. Rapid antigen testing might be able to play a role if people can get their hands on them at all. Where might they be helpful? We do not need to do it at the end of our isolation period. If we're asymptomatic and have been isolating as part of being a close family contact to someone, we just do our 5 days if we have no symptoms. So we don't really need to do a rapid antigen test there. If you believe yourself to be an essential worker and have exposure, and you feel that you need to come back to the office and work because perhaps you're a solo physician, or you are like me and don't have great internet and so can't really work remotely, So you may want to come back to your office, and that might be a good place to use a rapid antigen for those 5 days that you're supposed to be isolating, and do what they call a work, test work isolation protocol. You have to remember that you have to be asymptomatic though during this return to work, and you want to try to keep your exposure to the person that is the primary person that you would be exposed to a minimum. So there's very limited places I think that we can use rapid antigen testing at this point. I would say that for the most part, the fact that it's not available is maybe not the worst thing in the world.
I wonder how many people here have been able to receive any rapid antigen tests from HMMS. Back in November, if you ordered them, you were able to get them.
Yeah.
I'd be interested to know if anyone's gotten any that they've ordered more recently.
We've got an order in from 4 weeks ago that we still don't have, so I don't know that anybody else has had any luck getting rapid antigen testing from HMMS. I'm pretty sure that it's okay. So we have 100 rapids all gone. Yeah, an order not delivered. Yeah, I agree with you, Tanya.
HMMS does have a supply of rapid antigen tests, but there's been a prioritization criteria that's been created so that hospital or congregate settings which need them to have their employees work are getting access to them first. So unfortunately, the community-based providers are lower in the totem pole, if you want to call it. It's whether it's right or wrong, or you like it or not, it's what's happened. And so we just are not getting access. And to get it from a private company, hit and miss.
I guess
we use them in our nursing homes. We have an outbreak in one of our local nursing homes, and they're being used to test the patients actually, as well as the workers.
So some families are going to be given, I guess, a few rapid tests to take home to their school children. I wonder if we're going to get calls from families about when and how to use them and how to interpret them. Do you have any comments about that?
I don't think that very many people understand how to use them, when to use them. They've been instructed, I believe, to use them before they go to school, to start school, but I don't know that many people understand that. I think they use it to go and visit, Aunt Molly or Grandma or something of that nature, and assume that one negative is a negative. But of course, we know that one negative is not a negative. However, I mean, two negatives, 24 to 48 hours apart, are certainly much more sensitive than just one single one. So they certainly have some use there, but again, it's not really going to be used that way by most kids, I suspect, or most parents for their children.
Does anyone else have any comments about rapid antigen testing or questions about it? You can feel free also to unmute yourself. I believe that function is enabled. If you wanted to just say a question out loud, it's more convoluted than typing. If not, we can move on to another topic. Any other questions or thoughts? No? All right. Noor, back to you.
So just wondering about updates on hospital capacity, and I was hoping Scott and Stephen can give us a bit of an update, and maybe if we can start with Scott.
Yeah, sure. Thanks, Noor, and it's nice to see everyone tonight. Lots of familiar names. Some names I don't know. So for those of you who don't know me, Scott Mackay, family physician in town, and the MAC chair at LHSC right now. Just quickly give you a status of where the hospital's at. So the hospital does have a public-facing website that lists some of the numbers. If you're a credentialed staff, you can log in and get a little bit more. What the hospital released today, so they're at 135 patients who are currently admitted with COVID-19. This is well over the peak of wave 3. Wave 3, I think 102 patients was the peak. Now what they are doing right now is trying to differentiate between the patients who are admitted for COVID and with COVID. So there's actually 74 of those 135 patients are admitted for COVID, but 61 have been admitted for other reasons and just have COVID. ICU right now only has 24 COVID has 24 COVID patients. This is less than what the peak was in wave 3, but right now the modeling is suggesting that they will surpass the number of ICU patients potentially within the next few days. Just heard tonight at a meeting that the Hamilton Niagara area is very much over occupancy in their ICUs, and they are going to be starting to do some of the provincial transferring of patients between areas and ICUs, as they had to do in wave 3, and LHSC as well as regional hospitals are going to be receiving some COVID patients from out of region. Occupancy of the hospital 98%, but the med surge beds are all over 100. Many of the surgery beds have been flipped to COVID care. So we're seeing lots of COVID ward patients. In particular, there is plans for bed expansion depending on the number of COVID patients that come into hospital. The hospital has contingency plans based on specific triggers of number of patients admitted either to the ward or ICU each day to know when to expand. Obviously, Directive 2 has caused ramp down of surgical activity. So it's about 40%, I think is what most hospitals have needed to ramp down to for surgeries and procedures. There's been extensive redeployment of nursing and other staff within the hospitals because of the amount of COVID. I think the latest number was that there's 509 staff and physicians who are currently off work because they're positive for COVID within LHSC. Physician redeployment is on the table depending on where things go, and particularly a need that may be had for ward coverage patients if there's a further expansion of the number of patients admitted. I'll pass to Steve. He knows a little bit more of the Parkwood story and may have some other citywide updates too.
Yeah, thanks very much, Scott. So Parkwood Hospital, as you probably know, has been sort of a pressure release for LHSC. So when things get really bad in the acute care setting, the hospital looks to decant alternative level of care patients and subacute medicine patients. And one of the best sites to decant those has been to Parkwood Hospital. That's a little bit complicated with this wave because Parkwood itself has a series of outbreaks going on. They have 9 units in outbreak, and they have about 80 patients who are positive for COVID at Parkwood alone, although they're asymptomatic or very mildly symptomatic. Nevertheless, I expect if pressure increases on LHSC beds that they're going to look for ways to create capacity, and patients will be transferred to Parkwood. Now, they can be looked after by the family docs who have privileges there and are currently working there. But if there's a huge need to decant a lot of patients, or if there are family docs or doctors and staff at Parkwood who are off because of COVID exposures or COVID infections, then there will be a need for physicians to help us with managing those patients in hospital at Parkwood. So these again will be ALC type patients, subacute medicine patients, not acutely ill, but needing physicians to look after them. And that's an ideal setting for family physicians who are able and have some time to step up and help with that. So please be on the lookout. I'll be emailing you if there is a need for physicians to step forward and help us out at Parkwood. Thanks very much. Back to Noor.
Awesome. Thanks, Scott and Steve. We'll move on now to treatment of COVID in primary care, and I'll pass it back to Julian Gord.
Yeah, I'm really interested in hearing getting some guidance on treatment, because for the first time in the last year and a half, we really have the phones ringing with people having symptoms and wanting advice as to how to manage those symptoms. So I have a couple cases that I just gathered over the last week. Is there a slide that lists those? So there's 3 different cases. First case is a 28-year-old asthmatic woman who's COVID positive, but did not contact my office until day 9. At that point, her headache, sore throat, fever had resolved, but her chest tightness and cough were persisting. She was using Flovent and Ventolin. She was monitoring her home oxygen because she had an oximeter from a family member, and had been 94 the day before I talked to her. The day I talked to her, it was 97. So I'm just wondering what I should offer her today. I'm curious what I should have offered her if she had called me day 4 and was sitting at 94, 95 that day 4. So what would you say to that case, Gord?
Yeah, interesting cases. And so you're throwing some challenges and because of the uniqueness of the comorbidity. So I think first of all, in any case, it's really important that we want to ensure that our patients understand the concept of self-isolation and self-management, what symptoms to watch for, right? So that patient who's presented early is what are the changes to watch for, when to call you back, when things are getting worse. The fact that she has a pulse oximeter is great, but a lot of our patients who are COVID positive are not going to have a pulse oximeter. And so, as I mentioned before, there's 2 ways to get pulse oximeters. One is through the home and community care program, and through them, they will actually, it's an electronic tool through Vivify that allows patients to communicate back and forth using texting or email. So obviously it has to be sort of somewhat of the IT literate patients, but they have used it with senior patients. They've just done it by phone call with the nurses, but the nurses will monitor these patients. And it is a Monday to Friday. It isn't a weekend thing, but it gives you some external person who can monitor, and they have some criteria that if the patient is sitting below 92%, that there is a need for them, the patient to get a hold of, go into emergency room for an assessment. The COVID at Home program is a provincial program where you can order pulse oximeters for your office, and hopefully we'll put that up in the chat if we didn't already. So the idea then would be is that you would be monitoring these patients, and you have to get these oximeters to them. So this is a challenge too, is that if they're sick and they have their family members isolating with them, how are you going to get it to them? And hopefully, the one advantage of being in primary care is we often have larger families, the extended families, and we know are often these patients have extended families, and there may be somebody who could pick up the oximeter and bring it back to the patient. And really that key there, for most patients, it's the 92% or lower than 92%. Less than 92% would be your trigger. That sounds a little high, I said, when I first heard that. I thought, oxygen requirements would be when I see somebody with a PO2 under 90, but really what it comes down to is that they've seen historically that people are desatting early before they get symptomatic, and that's the time you want to see them. Your particular asthmatic patient is interesting because the use of Pulmicort has been brought in now, or budesonide inhaled is one of the treatments, and that's comes, the guideline how to use it's from the Ontario Science Table. And the dose is 800 micrograms a day, but this individual is already on an inhaled steroid. So, Julie, I'm not sure if there'd be an advantage to changing that person over to another inhaled steroid. The question is whether you can bump the Flovent up, and that may have been an option. In any asthmatic patient, whether a long-acting bronchodilator, what may also help their symptoms. And the other thing you can look at if you feel comfortable is using a codeine-based cough syrup to help their symptoms. Your patient, it always brings to the question is whether they need a chest x-ray if there's something else going on, if they got a secondary bacterial infection. So that other comes to mind. And the reality is if this is a COVID positive patient who's symptomatic, the Emerge may be the best spot. I've actually not explored whether our community-based x-ray clinics would be able to see that. And I'd be open to see if anyone else knows that. I just don't know the answer to that. I've not had to experience it, but if that was the case, I would have probably called and say, would you see this by a chest x-ray? And then the third thing is can you see them in your office safely? Do you have proper PPE to assess the person rather than just sending them for a chest x-ray? Because that would, I think, still be an important aspect. And everyone has different office setups. What we tend to do in our office is if I want to see somebody symptomatic is I try and book them as the last patient of the day. We tell them when they get there to give us a call because we may be running behind. We don't want them waiting in the waiting room. And so then we'll tell them to come up when we're ready for them, and we bring them very quickly into the examine room to examine. And the way our office is set up, we can get them down as long as they're mobile. This 28-year-old can get down through a back door and pretty much isolate from being exposed to any other patients. So that's kind of how we would manage here. This patient, based on her age, does not probably qualify for any other therapies, including the monoclonal antibodies. However, if she got into hospital and was quite sick, that may be a decision that our internal medicine and emergency physicians would make a decision on.
Okay. You mentioned the home monitoring program. How long does it take for a referral to get processed and the patient to receive the?
Yeah, my understanding is they're really trying to make an effort to get in contact with the patient within 24 hours. So within 24 hours of contact, so it still could be 48 for pulse oximeters, sometimes less. It's sort of variable, but they're trying their best to do that. They definitely have capacity right now, but as we advertise this more and more, they're going to get busier. Obviously, to order the COVID at home, I had not done that, and I ordered on Monday and received them on Thursday.
Wow.
So I was able to get 10. I think the criterion, they asked how many patients you had, and I think they gave you one per every, on the average, 150 patients that you have. I think that's what it asked. So I got 10 because I have about 1,600 patients in my practice.
Okay. My second case was an 85-year-old woman at home who has COPD and is on home oxygen, so high risk, positive rapid test at home. She did fine, though, in the first 10 days and didn't call me. Her daughter didn't call me until 10 days later. At that point, she was feeling like she was a bit more short of breath and coughing more at night. They still didn't want to make a fuss about it, but I was a little worried about her feeling a little worse 10 days later.
Mm-hmm.
My question is what to do at that point. All the guidelines talk about within the first 7 days. So what if she had been calling me earlier on, but yet still had the same, I'm feeling pretty much okay?
Yeah. So again, it's the comorbidities that's the red flag there, not just the COVID itself and the COPD. If that's the background there, that, and being on home oxygen would concern me. I think one of the challenges we're having now is that most of us had these patients were getting referred on to the LUC3 clinic, so the London Urgent COVID Clinic. And as of January, the London Urgent COVID Clinic is just not able to see these patients. And there's multiple reasons for it. One is they've had some reduced staffing. The volume of COVID patients is huge. And second of all, they were getting the referral done from the health unit, but the health unit has not been doing contact tracing anymore. So they're not getting the referrals from the health unit. And they're also just dealing with the inpatient COVID patients, as Scott told us, and the numbers that are growing. So we need to manage these patients at home. So again, this is going to be a decision of how much do I feel by talking to this family on the phone, this person is in distress. And so I would be concerned about an 85-year-old with COPD who's at day 10 with COVID about another comorbid infection or worsening of the COVID. And I think they're a high-risk person that probably should be assessed in an emerge room, unfortunately. I hate to send people there, but I would be concerned about that. If they presented in day 4, for example, you can definitely use the inhaled budesonide, but if they presented in day 4, for sure, I would consider using inhaled budesonide. If this is a COPDer, they may or may not be on an inhaled steroid already. A lot of COPDers don't need to be on inhaled steroids, but some are. But some people would say, should I use dexamethasone, those type of things? You're getting into that higher level according to the Ontario Science Table, and you're going to decide if that is an acceptable risk versus acceptable benefit. I think I would be really concerned about an 85-year-old day 10 being quite symptomatic.
What about if she's earlier presenting? What about the IV treatment, IV infusions? Are family physicians accessing that at all, or?
Yeah, good question. Yeah. So again, the IV infusion is meant to be for people who are more moderate to severe. They're really looking at certain criteria. So definitely anyone over the age of 70 with some comorbidities is going to be a potential candidate for this. The monoclonal antibodies have been giving them at University Hospital so there is a small percentage of patients who have been getting them. There's definitely some complexities to it. There needs to be lab work done, and it needs to be done in a monitored setting. So it should be done through an emerge visit. There's no direct referral for somebody for monoclonal antibodies. As we evolve with this COVID Clinical Assessment Center, or Clinical Assessment Center, it doesn't appear that we're going to be able to do monoclonal antibodies there because this will be at Carling and there won't be access to labs. So if somebody gets sent there in the future, which this could be a person who could get sent there, for example, in the future, and they felt they needed monoclonal antibodies, and they would be moving them on to the University Hospital for that procedure.
The third case, I don't need to go into it in detail, but it just illustrated the problem of someone not having a positive result yet. So what if he's just presented with the symptoms? We're going to wait 3 more days to find the results. He wasn't super sick, but if they're symptomatic and at moderate risk, I don't yet know for sure it's COVID, but should I be searching for budesonide? Should I be trying fluvoxamine?
Yeah, I think you should consider both. You know, what the reason is we have so much COVID in the community. We need to presume that most respiratory symptoms that meet the criterion, and there's definitely criterion, are potentially COVID. And so, you know, this says test pending, but right now they're not getting tested. So we're pretty much assuming they're all COVID. And you got to look at harm versus benefit. And I think the benefit potentially outweighs the harm of budesonide and fluvoxamine. The other thing that's interesting is that initially the guidelines of fluvoxamine in the Ontario Science Table didn't give a real details on how to titrate it. They just updated the Ontario Science Table with a guide to using fluvoxamine. And so it comes from the pharmacy school in University of Waterloo. It says start with a 50 milligram dose, preferably at bedtime if the drug is well tolerated, increase to 100 milligrams BID on day 2. And if the patient, then it says, if the drug is less well tolerated, consider it a 50 milligram PO BID on day 2, and then increase to 100 PO BID on day 3. It says if the patient's on another SSRI or SNRI, if the patient was on another SNRI before switching to fluvoxamine, and they were near the maximum dose, you can increase to 150 PO BID. So there's guidelines there, and you're supposed to use that for 10 to 15 days. So I've not used fluvoxamine yet. I've used budesonide. I know I talked with one of the physicians who works at the LUC3 clinic, and they said they've not used a lot of fluvoxamine at this point either. But I think it's an option that could be looked at.
Okay.
I see chats, but I can't read the chat and talk. So,
Gord, budesonide is not available. It's all on back order.
Yes. Yeah.
I think we need to bring that up because really it's not available for anybody to use. So the question, of course, is do other steroids have any benefit?
Yeah. So it's interesting, and it's a good question. I encountered that on Tuesday with making dealing with an after hours patient in our office. So, and I've only been told by Rexall, but I'm assuming it's all pharmacies are having that issue because the pharmacies go by different suppliers. There could be the odd independent that may still have some on their shelves, but I think they're all going out fast. So the first option is you could look at using is the combination of budesonide and formoterol, which is Symbicort. However, we also got to look at if this is an over 65 patient on ODB or a younger patient who's on Ontario drug benefits, is there you have to use an LU code. And so that puts an ethical dilemma because they're not technically an asthmatic. And so you have to decide based on your individual comfort level whether you would use that LU code or not. My understanding is there isn't, it's not that other inhaled steroids won't work, it's just that the clinical studies haven't been done. I haven't seen them myself. So I would consider that, you know, whether you want to use fluticasone or one of the other inhaled steroids. I always look at it, what's the harm versus the benefit? And so I think there's a potential benefit and a low risk of harm in these situations. So.
Bill, have you had experience with fluvoxamine or anybody else, and have you found it helpful?
We had a discussion, Julie Copeland's writing here, and Dr. Puente, Sarah Puente and myself had a discussion about our nursing home patients because when you're in an outbreak, very much like in Parkwood, the question is, what do you do for these patients who mostly have mild symptoms, but have lots of comorbidities and are often on lots of medications. So our thought really was, with the limited amount of information in terms of benefit, that for the most part, we weren't going to do very much for these patients because we thought we'd actually cause more harm than good. I can't really see fluvoxamine being something that I use with the dosage escalation that we see there, 50 once a day, then 100 twice a day. I mean, an SSRI that you're kind of moving up that quickly will give lots of side effects to people, and I'm just not sure that in the elderly population it's very good. The suggestion by the pharmacist, as Gord was saying, is perhaps not going up to TID but staying at BID. But again, you know, the studies aren't great. It's not like they're fantastic, and all of the studies are done on Delta and before, right? So we don't even have really any indication what it does for Omicron. So I have elected not to at this point. I don't know whether that's right or wrong. In the hospital, we certainly use the monoclonal antibodies and dexamethasone IV and all that sort of stuff when we admit patients. But you know, that's the moderate to severe, and that's not what the family doctor is going to be dealing with in their office.
That's a helpful comment from Sarah about the toll of escalating fluvoxamine quickly.
And there was also a really good point by Dr. Julie Copeland. So because Alvasco, she was saying a pharmacist had sent her a study saying Alvasco 200 micrograms, 2 puffs, BID 14 days. So obviously not on the science table guideline, but definitely an option. Thank you, Julie.
Awesome. I think we're nearing the end here, and we'll just open the floor to any questions that are still brewing that we haven't answered. Feel free to unmute yourself or type it in the chat box there.
Nora, I want to kind of maybe come back to some isolation stuff that I was kind of thinking about as some scenarios that had come up in some of our other discussions, and it was about people that had like multiple children that might get symptomatic at different times, and what do you do then? And it's not the answer people want to hear probably, but it is somewhat sequential, I think, is my understanding of what would happen. So if child number 1 got sick, and then you start your isolation for 5 days as a close contact, then child number 2 gets sick on day 4, then it's another 5 days, and then child 3 gets sick like on day 7, then it's another 5 days. So you know, it could be potentially up to 15 days of isolation if it goes badly for timing wise. So that is the guidance as far as I'm understanding from the flow sheets and flow charts.
That's tough.
Yeah, not what people want to hear, but that's unfortunately where we're at.
For sure.
And I guess maybe talking more about I'll chime in since everyone's being quiet here right now, but with the RATs, I know that they've kind of been a lot of demand for us. I'm surprised there's not more questions about that, but I think certainly my experience with my patients is that they hardly ever use them for asymptomatic testing. I mean, they sometimes will do it before the Christmas parties and that sort of thing, but for the most part, it's like they'll come in with some mild symptoms they don't really tell me about, then they'll say, oh, but I took a rapid test and it came back negative, so I'm here. And that's not really what they're supposed to be used for. I think we have to always remind people they're not really meant for symptomatic use. And really, it's really tricky for us to get out of this 5-day isolation. I think that as much as we want to get out of that 5 days sooner, I don't know if there's any easy way to do that, unless like Phil was saying, you did the daily testing kind of thing. But other than that, there's no real easy way to do that as much as we want to. And then I think the only other way we hadn't really mentioned too was that if you're working at a hospital long-term care congregate setting and you're at the 10-day isolation piece and you can maybe get back sooner if you take a negative test on day 6 and day 7 and they're both negative, then you can go back to work on day 7 at the hospital or at the long-term care center.
Thanks, Vineet. I'm not seeing any questions through the chat box. No one's unmuting there, so I might hand it over to Janet, unless anyone on the panel here wants to make any other comments, questions, concerns.
I do have another scenario, if I have time to ask it.
Sure.
I had a patient call me today who wanted to come and see me. She had COVID December 30th. Her mother, who lives in long-term care, became COVID positive. I'm not sure when exactly, but maybe we'll say January 10th. Anyway, she's in a long-term care that's in outbreak. The long-term care has said that my patient, the 50-year-old, I guess, can go to visit the mother, presumably because she's just had COVID. I'm not sure, but she's free to come and go. So she comes in and she visits her mother, and then she's out in the community and not told to isolate at all, despite being in contact with a long-term care that's in outbreak. Anyway, I just found that interesting and sort of strange that the long-term care home is letting family in. Do they have some criteria that they follow, that if that person has just recently been COVID positive, they're considered, they're not going to carry it back out? It just seems strange. And is that person fine to come into my office?
Julie, it's actually a very, I was going to say, it's a very interesting question, and there are very strict protocols for long-term care. They are unbelievable, all the policies that have been coming in, they constantly change. And I know the challenge is the long-term care administrators are finding that these policies are changing so rapidly that sometimes they get confused. I don't know what the policy is. I know there may be others that work in long-term care that may understand that, but talking with our long-term care lead at our leadership table that I'm at, it's interesting. Every week, it seems like there's something new that comes up for them that they have to be changing. So it makes it very confusing.
I'll just quickly comment. Certainly when you're not in an outbreak, the rules are different than when you're in an outbreak. So I don't know whether this patient would be just the only patient in the nursing home that has COVID, or is the nursing home in an outbreak situation?
It's in an outbreak. That was the phrase she used. Yeah.
Yeah. So they're still allowed essential caregivers.
Okay.
The essential caregiver can continue to go in, but general visitors cannot go in. So essential caregivers cannot be stopped from going in. That is an Ontario rule, basically. But they would have to wear a mask the entire time that they're with the patient.
But then should they isolate to the rest of their life out and about? Should they?
No, much like ourselves. I mean, they would not be at any increased contact. If she had not had COVID, you know, you would say to her, you know, if your mom can't wear a mask, you may want to wear a mask plus eye protection to sort of decrease the risk to her, but she would be at no greater risk than you and I meeting a COVID patient per se, as long as she's masked. And if possible, mom were masked, but I don't know whether mom would be masked.
Okay.
Steve just posted a question. If you have just recovered from COVID, how susceptible are you to another bout of COVID?
I think assuming it's the same strain, the reality is that you probably wouldn't be very susceptible. Probably within that 90-day period, they seem to think that you've got pretty good antibody coverage. Very similar to the vaccine. They certainly say even in people who haven't got great immune response, that usually, again, that 90 days is a pretty good coverage period. I think I said 30 the first time I meant 90.
I would also just add that my understanding is that for the hospital cases are not all getting subtyped. And so there is some concern that some of the hospitalization cases actually still may be Delta along with Omicron. So we can't make an assumption that, you know, from one strain to the other, that as Phil was saying, it may make a difference. And so, you know, anything is going to be possible. So, you know, always I like to answer these questions. It depends, right? So.
Yeah, that's why I said assuming the same strain. It's for sure.
Thanks.
All righty, I don't see any other questions. And we are at 3 minutes to 8:30. Thank you to everyone. There were more than 70 of us that joined us at the height of our discussion tonight. So lots of wonderful new faces and familiar faces as well. So thank you for taking some time out of your evening to join us. I did want to put this slide up because it's where you'll get the majority of this information. So Please subscribe if you haven't. You'll get our recording, all the links to the conversation here as well, and any other new and different changes that are happening. We do our best to try and provide them at a timely manner. So thank you so very much for joining us this evening. On behalf of everyone from the London Middlesex Primary Care Alliance, we hope to have more sessions soon with you, and always looking for feedback as well. So thank you so very much. Thanks for everything that you're doing in our community, and have a wonderful evening and keep safe, everyone.